Terrific. Hi, everybody. Welcome. We're so thrilled that you could join us today for part one of our series that Deep Connections is running with the LGS Foundation on rescue medications in severe developmental and epileptic encephalopathies. Excuse me. This is a space that hasn't received as much attention, and we're so excited to have a couple of people with us today who get it and are in it and want to help the DEE community get some better guidance and better plans for really dealing with rescue meds for those of us who live this all the time. So to start though, as always, we're going to bring in our family voice. And today we are joined by Krista, who is mother to Connor. And I'll let her go ahead and take it away. She's going to share a little bit about her experience with rescue meds.
Thank you, Gabby. My name's Krista Smith, and I have a 10-year-old son, and he has severe epilepsy. And therefore, through the course of what I like to say is 9 years, we've developed, I think, a pretty comprehensive plan for dealing with his particular type of seizures and what our seizure plan should look like. But it certainly was one that took many years to develop. And hopefully some of our learnings will help other families do it much faster than it took for us to do it. I like to say that for Connor, my son, we have a two-phase approach when it comes to kind of our living experience with seizures and how we want to go about treating them and what our end goals are. And we have what we call bridge the gap, which might be a day where he's having a seizure cluster. And we really want to use an AED medication that is not his typical daily medication to break up those seizure clusters. What our goal here is to avoid hospitalization. We do not want to end up there. We don't want to pick up germs there. We really want to be able to try and treat him at home as his loving parents and caregivers. So we don't do this by ourselves. We have a plan in place both with my son's neurologist and epileptologist, as well as his palliative care team, to really make sure we're communicating throughout the day to figure out if we've really addressed the seizure clusters using a medication. In our case, we use something called Klonopin, and we can use different doses until we max out to where his palliative care team, as well as his neurologist, are comfortable. At said point, if we were to max out, we would then obviously go to the hospital. Luckily, in our 9 to 10 years, we have not ever hit that max dose where we needed to then convert on a seizure cluster day and go to the hospital. So bridging the gap using something like Klonopin has really worked for us. And again, having that feedback throughout the day with his care team to make sure we're making good decisions as parents. We have things at home that help us make those good decisions. So we have a pulse ox and probe that we can use to see what his saturation levels look like, his heart rate while he's having those seizures, to see if he's still kind of in a safe range and if his heart rate's coming back down and his saturations are going up when he comes out of those seizures, as well as we have oxygen to help supplement. Again, we just would use a low dose to help supplement him through those seizures. And if it got to a point where we needed something more at a hospital level, we would not be afraid to take that path. That's kind of our first phase and what we try to do on those seizure cluster days. And then our second phase is what I call rescue. This is really where you think of you're having that prolonged seizure. In our son's case, it would be a tonic-clonic. It would go longer than 3 minutes. And during that time, he's also having an apnea episode, and therefore he's not breathing, which at this point we know oxygen is starving to the brain. And our end goal here is get him breathing again. And we likely know in this case, we're going to the hospital. I can say, have not had to use this too many times throughout the course of my son's life, but it's nice to know that we've got that plan in place. And the couple times that we've had to use it, it's good to have read the materials on how you use the medication. There are, variable medications out there, and I'm excited to learn about more today. In our case, we've used Diastat. It's been administered rectally. And again, just reading all that paperwork ahead of time and knowing how you would do that once you end up in that emergency versus being in that emergency and then having to figure it out. For us, our comfort level with his care team is at 3 minutes, we enact the rescue medication, and then we call 911 and kind of go from there. I would say that for every child, it's probably different. I think some neurologists that we've talked to are comfortable waiting to 5 minutes. So I think it really is one of these things where communication is key. The parent and the caregivers know their child best, and then being in contact with the neurologist, epileptologist, and or if your child has a care team that might include palliative care, just really making sure you're all on the same page of when you would do that. So I would say that's our 2-phase approach. And I'd like to say we had this plan from day one and that we're the perfect epilepsy parents, but we're not. It took us 9 years to really figure out this approach. But I'm hopeful that a phased approach might also work for other parents and might be good guidance, even for clinicians, to broach this topic early with parents so that they don't end up in an emergency or on a seizure cluster day and then have to try to figure out, what do I do now? I would also say that for us, having those protocols written out is really important, and then making sure that they're provided to any places that your child might be, whether they go to the gym, whether it's at their church, whether it might be their daycare or their school, having that really written out. And if you have time, going through that with the points of contact who can really be in charge in that moment's notice to be able to say, okay, this is this child's seizure plan and this is what we need to do to really help them get through this, whether it's, again, bridging the gap or whether it's rescue. And I'd have a couple of key takeaways, again, being in this for about a decade now. I think having an emergency contact for your neurologist and or their department is incredibly important. Maybe that's an email address, whatever way you feel like you can communicate most effectively, and not waiting till you're in that emergency to say, okay, what's the phone number? How do I get a hold of them? How do I tell them that my child's just had this really big seizure and let's figure out what our go forward plan is? So make sure you have that contact information. I also, this is really just something we've done over the last 6 months, and I wish we had done it way sooner, is connecting with your hospital or medical system's palliative care team. That can be kind of scary. And I know when it first was brought up to us, we were like, hold on a second, palliative care, that's, when you're in really dire straits. And what we learned was that that's not the case. This is a team of people that can get in touch with you immediately when you're in tougher days, tougher situations. They can help get a hold of your doctors faster than you can. They can help just bridge some of those communication gaps, and they can also provide advice if you just can't get a hold of your neurologist, epileptologist. So really reaching out and finding a palliative care team, I think, is key, and I wish we had definitely done that sooner. And then I would say, from the kind of going back to the phased approach of bridging the gap and then rescue meds, I like to keep those in multiple locations. So I like to keep a set that's in the bedroom. If I wake up in the middle of the night and I'm sleepy and I'm groggy, I don't want to be fumbling over the house trying to find my son's Diastat or his Klonopin. So just keeping 1 vial of the Diastat and a couple of his milligrams of Klonopin in the bedroom where he's already at makes that super seamless. As well as I keep them in the kitchen. I do that so that in a higher level cabinet that somebody short and little couldn't access, but keeping it somewhere where everybody in the house could access. If I wasn't there, if for some reason somebody else needed to administer that, they could find it. As well as his backpack. It is always in my son's backpack. So if we go on a trip, if we're walking out the door, even just to go to the grocery store, wherever we may go, that Klonopin and that Diastat is going with us. And then other important places, your school, your church, your, gym, wherever it may be that your child is, I would have, and if you're not taking your backpack with you, I'd make sure to have it located there as well. You just don't want to be messing around in an emergency, even on a cluster day, and trying to figure out where's that medication. And then also one of my key other takeaways is just checking the expiration date. And then at the beginning of each calendar year, I like to reach out to my son's neurologist, epileptologist, and ask for a new script for all of them. One, it helps me build our supply so that I can have those multiple locations. but two, would make sure that we don't have any expired medications. And if we do have any expired, it helps replace those. So I would say those are key takeaways. I think, from our living experience, rarely is your clinician probably right out of the gate going to be incredibly comprehensive for quite a few reasons. One, you might just be trying to figure out what seizure types do I have, and is this going to be lifelong? And you're dealing with all the real realities of my child has epilepsy, and what does this mean for us as a family going forward, and what does this mean for my child in their future? So sometimes this isn't right forefront, but I think after that kind of initial diagnosis and initial getting a grasp on that, this should be probably pretty soon thereafter put into place. And then again, thinking about kind of that phased approach and just other things that you might need in your home to help you really avoid hospitalization where you can. So do you need a pulse ox? Do you need even if it's a low level concentrator that would help you with a low level amount of oxygen?
Yeah, Krista, that's a lot of really fantastic advice there. And maybe we can post that on the website too. It's just like your advice from a very seasoned mom. And we also have some people echoing in saying they totally are with you on that phased approach, especially for clusters. So yeah, I think that was a really excellent way to open things up here. And so thank you, Krista. It's great to hear your experience. I think it's clear that you embody how our families have to be advocates, right? And push for what we think is right. And I love that, that you're working on making sure anywhere Connor is, people know what they need to do. And that's great. It probably relieves some pressure on you too, to be like, you don't have to be right there all the time. So finding those people you trust. Yeah. So thank you. Really appreciate it. We're gonna move on now to speaking or hearing from, I should say, Anne Berg. She's a research professor of pediatrics with neurology and epilepsy at Northwestern University Feinberg School of Medicine and at Lurie Children's. So we're going to start with Anne, who's going to give us share some of her research with us. And then we're going to hear from Dr. Elaine Wirrell, who is a pediatric neurologist at Mayo Clinic. So I'll pass it on to you all.
Okay. Well, thank you, Gabby, and thank you, Krista, too, for just a really beautiful discussion of what it is you live with and what I'm sure many other parents have to address every day. It's really a pleasure to be here with Elaine Wirrell and at your first in a series of critically important sessions on rescue medications and seizure action plans. And what I'd like to do is start off by providing some background from the perspective of a researcher, but it's background that I learned by working very closely with parents over the last few years on a couple of projects. I want to show you this diagram. This is a model that came from a seizure burden workshop that was really the primary participants were parents, plus some epileptologists and some other people, including myself. And parents such as Krista, such as Gabby, and all of you talked about what is it about seizures that makes life so hard. And it really came down to three sort of domains. One was how often they happened, you know that. One was their severity. And the severity entailed the emergencies, the crisis, the rescue meds, the ambulance teams, the emergency departments, admissions, the PICU, and of course the fear of death. And I think, Krista, you talked about all of those right now. And then the third thing was the unpredictability. They just happen anytime. You're going along and there's a seizure. And we started talking about life and living in a minefield. You don't know what's going to happen next. And that means that in between seizures, when things should be calm, they're not, because parents always have to be aware that there's a risk that this calm is going to break any second. You always have to be prepared, take precautions, and be on guard 24/7, 52. And again, Krista, you talked about this so eloquently. So that being on guard 24/7, 52 in part entails seizure action plans and having rescue medications. For the last couple of years, I and several colleagues have been involved basically on a journey to understand the natural history of developmental and epileptic encephalopathies, such as SCN8A, but many others, from the parent's perspective. This has been a little bit different from most other research projects because it has been designed with and by parents and researchers collaborating together. So we haven't just said, here, answer these questions, but we've asked parents, what is important to you? And what questions do we need to ask so that you can tell us about what you're going through? If you're interested in finding out more about what we've been doing, this is our website, earlylifeepilepsy.org. And at this point, we now have results from several of our groups that are up there in the forms of infographics, and these same graphics have been disseminated to the parent groups who have participated and now appear on several of their websites. But this is really parent-generated. So our first survey, and the one I'd like to tell you about in this context, had wonderful participation. Almost 300 families took part. The Dravet Syndrome Foundation really drove this to start with because they've been in advance of a lot of these initiatives. But we've had really wonderful participation from KCNB1 families, Lennox-Gastaut syndrome, KCNQ2, Cure Alliance, and some other groups as well, including ESIS and PCDH19. So one of the questions we asked, and the parents asked us to ask it this way, was, has your child ever had a seizure or seizure cluster that lasted over 10 minutes? And about 2/3 said yes. It varied somewhat by type of epilepsy, and that's okay. It may be critical to all patients with Dravet syndrome and most patients with Lennox-Gastaut syndrome, but I think this is really important, whether or not it's common for the type of epilepsy your child has. If your child has it, it's important, period. And you can see it affects a substantial proportion of all children with some kind of DEE. Now, I just want to mention this one slide, a little bit messy, but when we ask questions about rescue medications and prolonged seizures, we just focused on the past 6 months to get a snapshot. And that was because the purpose of this project was not to get a detailed history, sometimes going back over 20 or 25 years, but just to find out what was happening now. So you can see that almost all of the children with Dravet syndrome, all of the children with Lennox-Gastaut syndrome had recent seizures, and they are going to be driving a lot of the data that I'm going to present to you now. But most of the children with KCNB1 and other types of epilepsies, a little bit less so for KCNQ2, but just so you have that in mind as we move forward. So we asked, if your child has had seizures in the last 6 months, have they had a prolonged seizure lasting 5 minutes or more? A little over 1/3 said yes. About 1 out of 5 said they had had a seizure lasting more than 30 minutes. Convulsive seizures were very common, and when they occurred, these children had many convulsive seizures. It wasn't just one prolonged convulsive seizure, but multiple on different occasions. Likewise for non-convulsive seizures, very important for Lennox-Gastaut syndrome. A lot of myoclonic episodes that were prolonged, and others. And those others were not specifically identified as convulsive, but parents described them as being non-convulsive, progressing to convulsive, or sometimes convulsive and then becoming non-convulsive and going on for a very long period of time. In terms of the types of epilepsies that had prolonged and very prolonged seizures, we see it very commonly in Dravet syndrome. Half of them had had a recent prolonged seizure. Over 1/4 had a seizure lasting more than 30 minutes, but we see it in all of the groups, KCNB1, Lennox-Gastaut, others, and then a little bit less in KCNQ2, but if your child is the one who has that with KCNQ2, it's important to you. Almost 1/3 of the children have been taken to the emergency department at least once in the past 6 months. That's huge. If you look at your typical child, many of them never go to the emergency department, but 1/3 had been at least once, 18% had been multiple times, and you see a few had been many, many times, more than 5 times to the emergency department. Bridge and rescue medications were very commonly used. 43% said they had used a bridge medication. And I think, you know, Krista, you described that very nicely, the difference between a bridge and rescue. But 43% had used a bridge medication. And when they used it, it was often on multiple different occasions. Some of them 10 or more times. Again, rescue medications, 59% had used a rescue medication at least once in the past 6 months. And if they had, very few had used it just one time. Most of it was multiple times, with a good number saying they'd used it 10 or more times. Very important question, and one that again, the parents asked us to query about. If you used a rescue medication, was the first dose good enough, or did you have to use more than one dose? And the answer was that in about a third of patients, the first dose usually just did it. In another quarter, usually it did it. I'm sorry, in a third it did it, period. In another quarter, it usually was okay, but you had to be prepared with a second. For a chunk, it was half and half, and for a full quarter, either usually or always a second medication, a second dose was needed. And again, remember what Krista said about having enough doses on hand. The most common medications used were the benzodiazepines, no surprise there, but Diastat, very common. Nasal and buccal Versed are getting to be more common, which is good, much more convenient. Ativan, sometimes used in Klonopin. I'm going to let my colleague, Dr. Wirrell, comment on the use of CBD as a rescue medication. I don't think it's typical. And then there were some other approaches used as well, but mostly we see benzodiazepines being used. So, how many parents had a seizure action plan? All of this going on, how many had a seizure action plan? 58% had a plan, 42% didn't. And I thought this was high, but having heard what Krista just discussed, maybe that isn't such an atypical condition. Who does not have a seizure action plan? Well, a third of parents who said their child had ever had a prolonged seizure did not have a seizure action plan, and 2/3 of those who said their child hadn't had one. For the past 6 months, a third of those who said, yes, my child has had a prolonged seizure, still didn't have a seizure action plan. Not much different from those who didn't have a prolonged seizure. A little over a third of parents who said their children had had a 30-minute or longer seizure didn't have a seizure action plan. A little over a third who had used a rescue medication, who had used a bridge medication, and 42% of them who had taken their child to an emergency department said they did not have a seizure action plan. This is something we are really hoping this seminar series will change. We would like to see 100% of parents having a seizure action plan, knowing what that plan is. And often the plan is not going to be a single plan, but one appropriate for the home, one appropriate for the school, and one appropriate for other settings as well. So with that, I'm going to stop now and let Dr. Wirrell continue with the discussion about what appropriate drugs are and how one might go about learning how to use them.
All right, are you able to see my screen? Is everyone able to see my screen?
Yep, we can see him.
Perfect. All right. So thank you very much for inviting me to be part of this. And I'm going to be talking in a bit more detail about rescue medications and how those are a bit different in the population with the severe DEEs, and also a bit about seizure action plans. So we will start off with just a bit of an overview on what differences are there in rescue medication use in the DEEs. How do you choose the right rescue medication? And I think, as Anne said, it may be different depending on what situation you or your child is in. There may be something different at school than what you use at home. And then how often should rescue medications be used, and how often can rescue medications be used? And those are probably slightly different. And then we will address some tips to optimize seizure action plans. So if we look at what do neurologists actually learn about using rescue medications, And this is sort of the generic guidance. So people should use a rescue medication if they have a convulsive seizure that goes on for longer than 5 minutes. And oftentimes rescue medications are also utilized for seizure clusters, but if you actually look and try and find what is a good definition of seizure clusters, there isn't really one that's there. Many neurologists will consider a seizure cluster if you have 3 or more convulsive seizures in an hour, with each of those convulsive seizures lasting more than a minute. But this is very quite variable depending on who you talk to. There's not a great definition. I think what is fairly clear is that usually we're giving seizure rescue medication if the child is in a situation that is clearly different from their usual seizure pattern. And ideally, we would like to not be utilizing those rescue medications every day or every second day. So these are meant to be used as rescue and therefore more intermittent as opposed to daily medication. Now, there are some clear differences, though, in our population with DEEs. So in the children who have DEEs, most of the children that I know are having very frequent seizures. And in fact, most of the children that I have in my practice with DEEs are still having daily seizures or close to daily seizures. And so if you already are starting with that baseline, how do you actually define what is important worsening when you may want to be needing a rescue therapy? We know that in the DEEs, rescue medication is often used quite frequently, and I think Anne's data has clearly shown that. And we also know that in the DEEs, we use rescue medications a little bit differently. So you may not, for a convulsive seizure, you may not wait till it's prolonged. You may not wait 3 to 5 minutes. That really depends on your pattern and what type of epilepsy you have. You may use it differently for clusters of convulsive seizures, and you also may use it for clusters of non-convulsive seizures. So looking at the question of convulsive seizures, in some cases we know that there are children who, if they start having a convulsive seizure, they typically do not stop. And so in such situations, and probably the best example there is a young child with Dravet syndrome, it would be very, very unlikely for them to have a 2-minute generalized tonic-clonic seizure. If they start having a tonic-clonic seizure, it typically goes 20 to 30 minutes. And we know that there is a time, importance of time when we give the rescue medication. The earlier you give the rescue, the higher likelihood it is to work. And so while we don't want to be giving rescue medications willy-nilly really easily, we do know that particularly in such children who have intermittent seizures, but every time they have a seizure, it's prolonged, we want to give that rescue medication typically at the onset of the convulsive seizure instead of waiting 3 to 5 minutes. For clusters of convulsive seizures, I think we have to individualize. And so, for example, you really look at what the patterns have been in the past, and I think that's one thing with the DEE population. It's really important to individualize to find out what is that child's pattern, and families are really, really good at picking up patterns. So for example, if Danny has 3 briefer convulsive seizures in an hour, if the family says, boy, that's a real marker that he is going to have a long convulsive seizure in the next few hours, then even if they're not lasting a minute or longer, if there's 3 of those and they see that pattern, it would be reasonable to consider giving a rescue medication to prevent that long convulsive seizure from happening. The challenge, I think one of the biggest challenges that I run into as an epileptologist in treating children with DEEs is what do we do about non-convulsive seizures? Because children can often have quite frequent non-convulsive seizures. And there's really no clear consensus on how we should be using rescue medication in non-convulsive seizures or clusters of non-convulsive seizures. And here again, I think very, very important to individualize because people appreciate that there are patterns. So I think as most of you know who have children with the DEEs, frequent non-convulsive seizures are often the rule. And if it's the regular pattern, we certainly don't want to be giving a rescue therapy every day for that. That may mean that there needs to be an alteration in the prophylactic treatments that they're getting, but it shouldn't be a rescue treatment. So for example, David, who has recurrent brief myoclonic jerks with absences 6 to 10 times per hour, if that is his usual pattern, we would not jump in and rescue that. However, sometimes we can identify that this is indicative of a more concerning pattern. So for example, Beth, who has recurrent periods of non-convulsive status epilepticus, so back-to-back seizures that can last 8 to 10 hours, and these happen once or twice a month. And if they typically would require hospitalization, if you can identify what is the pattern before these start, can you actually intervene before she goes into non-convulsive status? So in that situation, if the family said, boy, when she, as this start, she's having back-to-back myoclonic jerks, then we would say, well, geez, maybe that's a good time to try a rescue medication to see if we can actually prevent the prolonged non-convulsive status epilepticus from happening. So then the question on how to find the best rescue medication option. And as we have already identified, there's a number of options that are out there. So Diastat, I think, has been sort of the tried and true. Many people have had experience with that. There is Diazepam or Lorazepam intensol. There's a clonazepam oral disintegrating tablet. And then recently we have two really, I think, important additions, nasal midazolam and nasal diazepam. So Diastat, I'm pretty sure you're all pretty familiar with this, but just let me go through this. So this is actually prior to the approval of our two most recent nasal preparations. This used to be the only FDA approved rescue medication. And it is FDA indicated for children aged 2 and older, although we certainly do use it, and I think it can be used more safely in younger children as well. The dose really depends on the child's weight, and you need a lower milligram per kilogram dose for the bigger the child. And typically this comes as two main sizes. There's a sort of a 2.5 to 10 milligram, and then 12.5 to 20 milligram. And the neurologist prescribes the dose, and the pharmacist dials it down to the appropriate dose. Intensol, Diazepam or Lorazepam intensol, this is not FDA approved for seizure rescue, but it is often used by neurologists. It comes as this vial, and inside the vial is actually a little eyedropper with a marker on, so it tells you what dose you give. So it does require that person giving the medication to actually draw up the appropriate dose. The doses really depend on what you're giving. So Diazepam, 0.1 to 0.2 milligrams per kilogram, Lorazepam about 0.05 milligrams per kilogram. One of the differences is that Lorazepam needs to be refrigerated, and so that's a problem if you have to remember to, take it out of your purse, put it back in the fridge, take it from the fridge, put it back in your purse when you go out. It's easily forgotten, and it is given into the cheek cavity buccally. Clonazepam oral disintegrating tablets, these are also not FDA approved as rescue, but they are FDA approved as prophylactic treatment of seizures. But because they can be easily administered and they're rapidly dissolving when they're placed into the cheek cavity, they're often used as rescue. And the dose ranges here anywhere from 0.125 up to 2 milligrams, depending on weight. And then the two newer ones are Valtoco. Valtoco is a nasal diazepam, and it comes in this pre-dosed device here, and you basically just put that up a nostril and you squeeze the plunger, so it's very, very easy to give. Nobody has to draw up anything, so you don't have to worry about giving the wrong dose. And this has now been FDA approved for seizure rescue therapy in children who are 6 and older. And it comes as a number of different doses, 5 milligrams, 10 milligrams. And then there's nasalam, nasal midazolam. And that is a very, very similar device. And again, you put it up the nose and you squeeze the plunger. And that's been FDA approved for people 12 years and older as a rescue medication for seizures. So I think very exciting. We now have sort of two newer nasal options that are officially FDA approved. So what one is right for your child? And I think a number of things to consider. So first of all, effectiveness. Despite the fact that these are all benzodiazepines and kind of all the same class, we do know that some children respond better to one of these agents than another one of these agents. So you're looking at what has worked in the past. You're looking at potential for side effects. Many of these agents will cause some sleepiness. At higher doses, they can cause some breathing difficulties. Sometimes the children kind of rev up and have more behavioral disinhibition. I think what's really important is looking at how easy is it to give this, and are you able to administer this? And oftentimes, if we are asking our caregivers who look after our children to draw up a certain amount of medication. There's more room for error there, and many of them are less comfortable doing that. Oftentimes people are also uncomfortable administering a rectal medication. And so I think in this situation, having those pre-dosed devices to administer nasal medications is going to be very, very helpful. There's the issue of social embarrassment with Diastat. If we're giving Diastat in a more public setting, that is of concern. And then insurance coverage and cost. So Nasalem is approved for 12 and older, Valtoco for 6 and older, and they are a bit more costly than the other options. So who can give rescue medication? So Diastat, if you look at the package insert, it says that a caregiver administering this should review the steps with the prescribing physician. And so that certainly, you know, the physician often will review how to administer this with the families, but they typically don't have the teaching assistant come in or things like that. And so I think it is important whoever is going to be giving this is taught how to administer this appropriately. And there's a few options online, and as well, many of your neurologists will have epilepsy nurses working with them that are also very good at showing people how to administer this. Clonazepam oral disintegrating tablets, Valtoco and Nasalem are super easy to give, so you probably don't need a lot of teaching for that. You do need a bit. But there is certainly more concern if you're having to draw up a certain amount. I think you have greater room for error. So if you're using a intensol preparation, the liquid, where you're actually having to drop a certain amount, or if you're using nasal midazolam, using the IV vial, where you have to open up the vial and drop a certain amount, there's often hesitation to use those because there's greater room for error. This is a video that the Epilepsy Foundation has put online. It's on YouTube, and if you search Rescue Medication and Epilepsy Foundation, you will find it. And this is a nurse, and she goes through how to administer the various types of rescue medication. And so this can be, I think, a really good resource for teaching assistants or other people who may be administering rescue medication to your child. So one of the questions that often comes up is how often can we actually give these rescue medications? The FDA guidance is really not terribly consistent with what's done in the real world. And so if you look at what the FDA says for a Diastat, is that it should not be given more than 5 times a month, and it should not be given more than every 5 days. And I think from Anne's survey, we see that there's a lot of people that are breaking that law, including me. Valtoco should not be given any more than 2 doses 4 hours apart. Again, should not be used more than 5 times a month, and no more than every 5 days. And then Nasalem, 2 doses 10 minutes apart, no more than 5 times a month, no more than once every 3 days. So that's sort of the FDA world, but we know that the real world is actually very different. Oftentimes kids are having seizures more frequently. So what is the risk of overuse? The risk of overuse really is if you give too high of a dose at one time, and that can actually lead to respiratory depression. And it sounds like, and I know a lot of people have oxygen in their homes. A lot of people have oxygen saturation monitors to look for this, but we do have to be cautious about respiratory depression and excessive sedation. If you're giving it too often, you can actually decrease the likelihood of how effective it's going to be. So you kind of, your receptors for your benzodiazepines kind of get used to this, and they don't work as well. And as well, you can develop tolerance and a risk of increased seizures if you try and reduce the dose or the frequency. So what do you need to do if you're requiring rescue medication more often? You want to discuss seizure control with your neurology provider. Maybe you need a change in your prophylactic therapies, and maybe your child is going to be a good candidate for other options if the prophylactic therapies are not working. So we know that many cases, the ketogenic diet can be helpful. Sometimes palliative surgical options, such as vagus nerve stimulation, can be helpful. So what if your seizure rescue medication doesn't seem to be effective? One of the big questions is it the right dose? And remember, children grow. And so in addition, I think as Krista said, to really look at those seizure medications at least every year, and certainly if your child is smaller, you want to look at them more frequently with your neurologist to really make sure that what was the right dose a year ago is still the right dose for your child, because all of these are weight-based. And one of the most common reasons we see why these aren't working is because they are not being used at the right dose. In addition, most of the children who have DEEs have some tolerance to medications. Many of them are already on benzodiazepines. And so generally they need the higher end of the dose range in order for these medications to be effective. So that can be another reason if you're using the lower end of the dose range, it often doesn't work as well. And then the question of if one rescue medication hasn't worked for several successive treatments, typically then we would go on to try a different agent if we know that medication has been used or has not worked at the right dose. But there's actually very little data. There's not been any studies to know how successful it is to switch from one rescue therapy to a different therapy. So just a couple of words about optimizing seizure action plans. It is important to pick the right rescue medication for you. If other caregivers are involved, you want to try and find one that they're comfortable giving and that they can give very quickly. I think clear guidance and I think seizure action plans are much more than just finding a rescue medication. As Krista had talked about, sort of bridging the gap is really important, and we place a lot of emphasis on that, sort of the pre-rescue period. Is there anything that you can do before you actually need a rescue? And sometimes that is giving an extra dose of the medication that you're currently on, or trying to give a different type of medication that's not typically your rescue therapy. You need pretty clear guidance, and you need to come to a consensus on what should and should not be rescued, what types of seizures. I think knowing whether you can repeat the dose, if so, how much can you give the second time, and how long should you wait in between the first and second doses? And then really when to seek emergency care and when to call 911. We don't want people to kind of be in a guessing situation. We really want a pretty clear plan. You know, this is what you give, you try this again. If it doesn't work, then this is the plan. In the ER, so what should be done here? Many pediatric hospitals will actually have cookie cutter approaches for status epilepticus. But these are pretty generic approaches, and we know again that many of your children have been tried on various therapies, and you know what works and what doesn't work. And so in that situation, I think we need to have an individualized plan. It needs to be worked out as a project between the parents and the healthcare provider, looking at what's worked in the past, what's not worked. And ideally, this should be written out on letterhead. Oftentimes in the medical record systems now, you can actually include this in a chart as a care plan, so that the care team can actually bring it forward when they know your child is coming in. In smaller local hospitals, oftentimes they will allow these plans to be housed in the ER, and then also for the families to carry it in your person wallet. Many of the smaller ERs are not used to dealing with children with seizures, and particularly children with very challenging seizures, and they are very, very appreciative if you come out with a rescue plan that they can follow. So I'm happy to take any questions, and I think Anne would be happy to take any questions as well. Thank you very much.
All right, thank you so much, Elaine and Anne. Some really fantastic information that you're sharing here, and information that people are really looking for. We got one comment that somebody had been searching for the FDA guidance and risk of overuse. And somebody else commented that, remember that rescue meds are controlled and highly sought after, so they should be locked up if you're living with young adults and somebody coming in.
Important for the young kids.
You know, that's an issue for sending them to school as well, and especially when you've got an older child, an adolescent who might be in a school with other adolescents. And I think there's been some tension between the schools and the parents about what is allowed on site. And I don't know, Elaine, if you have any thoughts about that.
Yeah, so I think most schools are not comfortable kind of having medications sitting in the child's backpack where other kids could get to them. I think some of the schools will actually let them be housed in the classroom with the teacher. Some of them only let them be housed with the school nurse.
Yeah.
Does anybody have any thoughts? Maybe people that are on the call, any experience that they've had?
Let's see, is anything coming in? We can come back to that if it comes up. I'm not seeing anything right now. We've got one question about determining max dose of clonazepam. I don't know if you want to take that, Elaine. I think there's some, I'll let you take it. I'm not going to comment.
I think it really depends on exposure again, and I would say that from my standpoint, I am not very comfortable going above sort of 0.8 to or 0.08 to 0.1 milligrams per kilogram, but that's even a pretty high dose, and I think you would need to. That's a discussion I think to have with your primary care provider who is providing this action plan for you, because certainly with all of these medications, too much can actually result in respiratory depression.
Definitely something to keep in mind. And that's why it's so important, as Krista was mentioning, that if you're going to be giving these kind of rescue meds, it's probably optimal to have a pulse oximeter at home to be able to monitor. An important point. Somebody asked, is Nasalam readily available?
It is available for prescription, and a number of my families have obtained that. It is, as I said, approved for 12 and older, so I have not had a lot of success getting it approved for patients less than 12. Even for patients older than 12, not all insurance companies are covering that, and so we are doing, it's pretty recently available, so some of them we've managed to get approval, some of them we've had flat out no's, and some of them we're still going through the prior authorization process.
Mm-hmm. Terrific. We got a question in. Somebody is asking about whether an administration of a rescue med once or even twice requires follow-up to the ER. They're saying they've been giving a variety of different answers by physicians and other folks about if and when that visit is needed. And frankly, that using a rescue med is directly related to hesitancy to go to the emergency room. Right? People are trying to avoid that for a number of reasons.
Yeah, so I think if you are using a rescue medication and that's something your child has clearly had before and you have experience using this particular rescue medication, there is absolutely no need for you to go to the ER, particularly if that seizure has stopped. The concern would be if your child had increased, if you were concerned about their breathing pattern afterwards, then you certainly would. If you were concerned that the rescue medication didn't work and they were still having seizures ongoing, then you would, but just giving the rescue medication, you would go to the ER, they'd probably turn around and say, thanks for coming, and send you home and ask you to call your neurologist. So I don't think you gain anything from going to the ER on a routine basis.
Yeah, and I think that's something that's particularly scary for folks now with coronavirus and a lot of us wanting to steer clear. But that's a really important point. What is your usual approach in terms of advice to parents with going to the ED again, but in the setting of rescue or bridge therapy, like in terms of how you decide what the point of going is?
Mm-hmm. So I think that, you know, I think those are two different things. So there's bridge therapy, which is really the goal to prevent a seizure emergency. And then the rescue therapy is what to do when you are faced with a seizure emergency. So I think for bridge therapy, if your bridge therapy is not working, particularly in the situation now where there is coronavirus in the community, my advice would be to, if you give a bridge therapy that's not working, try and reach your local provider, your healthcare provider, to see what other options you have without taking your child to the ER. I think for the ER, I would limit that to when you really are in a seizure emergency and your seizure rescue medication is not working.
Yeah.
And any comments you have?
No, except to say that this is why you need a seizure action plan, because a lot of this should be specified. And I know there's a tension between having everything written out, so you have a really long plan, and I know the schools don't like that. They want a single page plan versus having that single page plan and then all of these questions. But I think if these are common issues for your child, these should be specified in your plan to the extent possible. To the extent that you can foresee them, they should be specified.
Mm-hmm. Yeah, your research from discussions we've been having with people that it's so varied, it's so individualized. You've got to decide what works for your kid, discuss it with their providers, and come up with a plan. You know your child best, and they know the safety. So putting those two together, and that's something that's really critical. And I think also in that kind of situation, as Krista brought up, her son Connor is in hospice care. My son Elliot's been in hospice care for 4 or 5 years now. And that's, I think it's really a misnomer that in pediatric hospice care is not end of life. It's about palliative care. It's about comfort. It's about increasing your access to providers. I mean, we have somebody we call at 3 a.m. if we need to, so that we can get advice and guidance about how to stay out of the ED. So I think, that's a critical thing for people to ask about. And then of course, starting these conversations with your pediatric epileptologist or neurologist if you don't have a clear plan.
I just wanted to add, there's increasingly in the United States and probably elsewhere, there's an emphasis on getting a seizure action plan. We have a new law going into place in Illinois that requires all schools to be aware of the child seizure action plan, but we have the idea of an individualized education plan, an IEP. I think for children with DEEs, we need the idea of an individualized seizure action plan, because you will get these cookie cutter forms. And I think we have to be very careful not to accept that, we have a seizure action plan because we filled out this cookie cutter form. It does need to be individualized in these children. And maybe we should start talking about individualized seizure action plans, not just SAPs.
Yeah, I love that. That's a great point, Anne. And I think that's part of the reason that LGS Foundation and Deep Connections has really decided to focus in on this. And, we're so grateful that you all were here to help us do the kickoff. But the idea really is that this is something that every family should consider, think about, run the scenarios, have a plan, engage with discussion with your clinicians, and know what's going to work. And I loved when Krista was talking about all the different places, right? Have a scenario for here and for here and for here. And I think it puts your mind at ease a bit. I think probably being able to know that you have this thing that lays it all out. And in the midst of chaos, you don't have to stop and think as much. You can just say, okay, like we've thought about this when we have cool, calm heads. What is it that we're doing? So, yeah.
Yeah, I would take that even a step further to say within the school system, especially since that's where a lot of children spend so much of their time, it's making sure that not only do you have your seizure action plan, and I love the idea of it being individualized, but that you have more than just the nurse knowing it or the school teacher, because what if that school teacher's out that day, or what if the nurse happens to be out that day, or what if they're out on the same day? So I think really just making sure you have multiple points of contact that have your child's best interest.
Yeah, no, I think that's great advice. Somebody is just also echoing the importance of having a pulse oximeter and an oxygen concentrator or access to oxygen, particularly for folks who are living in rural areas, right? If you're going to these smaller hospitals that don't know how to treat your child's particular DEE and epilepsy, then it often can lead to over treatment. So, all right, we've got one more question here that we're going to ask, which is somebody is mentioning that their child has a really sensitive nose and whether nasal-am can be given orally.
So we don't know. Also, I think that when it was looked at and when they looked at how it's absorbed, they looked at when it was administered through the nasal route. In Europe, people have given buccal midazolam, so we know that that is given, but whether this this particular product is okay to give buccally, we don't know. We don't know.
Yeah, they're still relatively new, so I think we're learning more, and we'll have to do more research, right? Terrific. Well, we are just about at time here, so I want to give a huge thank you to, let's see, sorry, is my screen showing? Here we go. I was trying to pull up this slide, excuse me. To all of our speakers, it was really fantastic, Krista, to hear your experience and share your wisdom, and the research that you're doing is so fantastic, and we're grateful that you continue to be in this space for our DEE kids. And Elaine, the fearless pediatric neurologist who's really doing a lot of this great work. So we're grateful to you. We also want to make sure that we mention, you know, both from Deep Connections and LGS Foundation, who is planning this series with us, that this rescue series has been made possible with support from UCB and Neurelis, who have the new nasal medications, the Nasalam and the Valtoco. And you'll hear more about those. We've got webinars 2 through 4 in the Rescue Med series for severe DEEs coming up. These dates are still tentative. We're firming things up, but July 1st, we'll hear from a leading clinician and share some more details about each of these, the type of rescue meds that are available and how they work and what they're good for in particular. July 15th, the lived rescue experiences of DEE families. We're going to have an opportunity to hear more from folks, from families themselves, about the rescue meds that they use and how they've really developed their own seizure action plans, which will then help guide us into our final component of the series, which is actually digging in and developing those individualized seizure action plans. And thank you for that term. And it's going to be peer-led, hands-on. We'll be providing the templates for people to adapt and kind of make their own, so that people can really have something in hand that provides them the answers that they need in these difficult situations. Deep Connections also has a webinar next week, which is an update on the coronavirus vaccine development with a special consideration for the DEE population. And that is being done, we're holding that in conjunction with NIH and University of Maryland pediatric vaccine specialist. So thank you again to everybody for joining us, all of our participants. Thank you for your wonderful questions. Thank you for taking time out of your busy schedules. We hope that this was really useful, and we will have this webinar up online within about 48 hours, and we'll send out notice so that you can go back and listen to parts if you missed something, rewatch it, share it with your communities. So with that, I'll say thank you. Let everybody get back on with their busy days, and we'll see you next time. Thank you, everyone.
Thank you.
Bye.
Bye.